Okay, do you have my voice? Yeah, it seems that it's okay. Okay, good morning to everybody. We are so happy and honored to have this journal club. This is the third journal club of Community Oral Health Department in Tehran University of Medical Sciences. And we are so happy to have Dr. Mohammad Moharrami with us today, a former student and a distinguished colleague which is now working at Faculty of Dentistry, University of Toronto, Canada, and also is a member of topic group Dental Diagnostics and Digital Dentistry at Geneva, Switzerland. Okay. Dear Dr. Moharrami, thank you very much for being with us today. The topic and the article that we want to discuss today, I think it's a very interesting article because it's two fields that they are progressing rapidly, which is AI and also photography. And the dental care is that all of us know that it is a public health problem at global level. Okay, so please, the floor is yours.
Yeah, thank you so much for inviting me, and it's such a pleasure to be here. So before tackling the paper discussing like different aspects of it, I thought it might be useful to provide some background regarding like AI research in general, and AI in healthcare. It might provide some background in understanding and interpreting the paper maybe a little better. And then we can have the open discussion. I didn't provide any slides specifically. I thought maybe informal discussion provide a better stage for our discussion, but please stop me whenever you have a question, then we can delve into more details. So I'm not sure what is the background of the audience, but I start with very basics of machine learning. There is a formal definition, what is machine learning and what it does. So based on a formal definition, it's a field of artificial intelligence that enables computers to learn algorithms and make decisions from data without being explicitly programmed. So what it says is that with machine learning, you do not need to explicitly program and tell computer what to do. You have a data, you feed it to a machine, computer, and based on the distribution of the data, it decides the best algorithms for prediction. So for example, if you have sets of risk factor or features such as age, sex, smoking habit, alcohol consumption, you do not need to tell the computer, we have a patient, age over 50 years old, male, smoking, and has a history of alcohol consumption. So this specific patient has a high risk for cardiovascular disease. Based on the data you feed to the machine, it decides and interprets the best algorithms and rules and cutoff points for you. So that's first thing about the definition. The other thing that may provide misconceptions and maybe mis-expectations regarding what AI can do is the task, the analytical task that AI can do for us. So in general, we have three analytical tasks when you look at from perspective of biostatistics. We have descriptives that tells us about distribution of the data. We have predictive tasks that you predict something gonna happen or not, and you have counterfactual analytic tasks. And the most common misconception I saw during the research, and people nowadays even doing it, is to confuse prediction with counterfactual analysis. So counterfactual analysis is a scenario that you say, what if the condition was otherwise, and in that condition, what would happen? The very clear example of this is RCT or randomized clinical trial. So you have a control group and you have a case group, and you see what happens like if we provide this type of intervention. So AI cannot do this or substitute counterfactual analysis and those type of research design that provide those type of results for us. And I know the interest in the medical field and dental field is to manipulate something. We are interested in interventions. We want to find the risk factor to change it. But this is the area that AI is not built for. It is really good for prediction tasks. And prediction tasks, if you want to have a concrete example, maybe to saturate what it does, is that you have a logistic regression model and you find out that in this logistic regression model, smoking have an odds ratio of 2 for developing cancer, meaning that people that smoke has 2 times more chance of developing cancer compared to people do. But in this multivariable model, you have, besides smoking, you have other factors like income, like insurance, and like a bunch of others. What AI does for you is that take into account all of these risk factors and provide you with a global estimate and a probability. And this probability is usually between 0 to 1, like 100%, 0 to 100%, and tells you that this specific individual has an 80% of chance of developing cancer. So there is a difference between providing that probability, saying that a person will develop a cancer, and saying that smoking, people that smoke have 2 times more chance of developing cancer. So this is the distinction, and the most important one. So in terms of, so now we know that AI can provide prediction for us, but how does that ML model do it? Like how they approach this problem and provide solution to it? There are 3 paradigms in machine learning, how the models tackle these problems. We have either supervised machine learning, unsupervised machine learning, or reinforcement learning. So in supervised machine learning, we have a series of risk factor or features, or X vector, and our model map these X vector or features to our outcome, which is Y. For example, like it's similar to things that we are used to. You have a bunch of risk factors, and the model says that if you develop something or not. In unsupervised learning, you don't have any label. So you have your risk factor, but you don't have any label for this risk factor. So you don't know the ground truth for your data. You don't know who will provide dental care. You don't know who has dental care right now. So you feed it to the system, and based on the distribution of the data, the system makes cluster of this data. So if the system thinks that in an area that we have more density of the data, it attributes that density to a specific cluster like caries or cancer or whatever the outcome it is, and the rest to other clusters. So that's unsupervised learning. Besides this, we have reinforcement learning. And reinforcement learning is like the way the computer, for example, learns to play chess. You have an agent, the agent has a policy, and based on this policy, a specific policy, the system takes an action, and based on this action, you have a reward or penalty. And based on this reward or penalty, the system revises its policy and try to train itself to reach the best results. So it is important to understand that in healthcare, 90% of the models we are dealing with are supervised learning, meaning that we need labeled data, and having this labeled data need subject matter experts. So for example, if we are in dental field, we need subject matter experts to look at the photos, to look at the radiographs and label them as caries or not, for example. So this is about the types and paradigms of machine learning. The next thing is important when you read a paper about machine learning AI to try to understand and interpret the result is that to differentiate between 2 types of prediction. So when we say prediction, it does not necessarily mean you predict something or define something in future. We have 2 types of prediction. One is diagnosis, and the other is prognosis. And this comes from tripod statements. If you're interested, you can take a look at it. It is equivalent to consort that we use for our RCT reporting studies that use RCT. So the equivalent of that is tripod statement. So what does it say, this tripod statement, and what is diagnosis and what is prognosis? Diagnosis is something that happens at the current time. So you look at the image and you want to say right now if the patient has caries or not. On the other hand, prognosis is something that happens in future. So you have a bunch of risk factors, and based on this risk factor, you want to say if the patient will develop cancer, for example, in 5 years, or what is the survival rate of patients that already have cancer. And there is a very important differences between diagnosis and prognosis in terms of the data set. Most of the diagnoses, like the problems of diagnosis that we want to find solution to them, are based on unstructured data. And unstructured data is something that intuitional to humans, like image, like text, like voice. This type of things are unstructured, like we can understand it really easy. On the other hand, prognosis, when you want to build a model for prognosis, they're based on structured data. And structured data in nutshell is tabular data like Excel, CSV. The way we are used to work with data, like you have an Excel table and you have your risk factor, like again, for example, age, smoking, and etc. And why is that important to make this distinction? Because if you want to work in this type of problems, there are different models for unstructured and structured data. And you need different teams and set of skills to develop this machine learning. So structured data, which is tabular, are mostly based on machine learning models, which are more traditional. Unstructured data like image, text, or voices, these type of things are based on deep learning, which is more advanced type of models. And besides that, the other difference is that when you're working with structured data, like tabular data, you don't need very huge amount of data. But when you're working with unstructured like images, if you want to train a model, you need a lot of data. And by saying a lot of data, it means something around 10,000 images, for example. So that was about what machine learning can do, its prediction, the paradigms, and the type of data. And based on the type of data, right now we know that which type of model we want to use. So in terms of traditional models for structured data that I mentioned, it can be something as simple as logistic regression. Like in terms of how you use and approach logistic regression, it can fall in the realms of machine learning. But there are other examples like decision trees, random forests, XGBoost, SVM, and neural networks. So when you hear or read something, read this type of models or come across them in the paper, you can have an kind of understanding or intuition what type of data you're dealing with, what is the question and what is the solution provided to this type of models. On the other hand, we have deep learning, which is a subset of machine learning and more advanced models. And just quickly touch on models that are used for text data, then we are talking about image data, which is like the topic of our today paper. So for text data, the general or the umbrella term of model that we use are NLP or natural language processing. And these models can include RNN, LSTM, and transformers, and also large language models. Maybe the best example is ChatGPT. I guess most of you have already used this large language model. So these are example of the algorithms that we use to work with text data. On the other hand, when we are dealing with image data, it goes under the realm of computer vision. And again, when you are talking with a person that comes from computer science or machine learning background, it is important to ask this type of question. What are their experience? What they have worked before? What is their area of expertise? Because like when you say someone is machine learning engineer or they have experience, if you want to collaborate with them, it's like dentistry. You have different specialty like orthodontic, restorative, etc., etc. So it is important to understand if you want to form this collaboration or even understand the literature and paper you are reading. So for computer vision, there are three types of tasks that is important to be understood. When people say that we are working on image recognition, we are working on computer vision, what they mean by that. And these three types of class of tasks that are possible to provide solution for them in computer vision are classification, object detection, and semantic segmentation. So what are these? I shortly touch on them in the introduction of this paper, but in a nutshell, classification is a system. You have an image and you look at it and you attribute a label to the whole image. So you say in this image there is a dog, or there is a cat, or there is a dental caries. So you have an intraoral photo and you just look at it, and even if you have one single caries, you say there was a caries in this image. So that's classification. Object detection is classification plus localization. And in this type of model, you actually draw a boundary box around your outcomes. So if you have an image, for example, intraoral photograph, you draw a box around the tooth that have a caries, and you do not draw any box around other teeth that are found. So that is object detection. And the other task that some models can do for us is segmentation. And in segmentation, you take a step forward and you actually contour your outcome. So instead of drawing a box around your outcome, you actually contour it. You exactly say where is the caries in this tooth, that like a specific tooth or image that you have. So in a sense, it is pixel-wise annotation. Instead of you say that in this image, that tooth, that specific tooth has caries, you say that these pixels of the image has caries. And again, there are different models that are built for each of these tasks: classification, object detection, and semantic segmentation. And we try to separate these models in our results and discussion. So example of the models can work for classification are ResNet, Inception, and MobileNet. Example of the models for object detection are YOLO, STD, RCNN. And example of the models works for semantic segmentation is UNet and Mask RCNN. And we can discuss these models in more details during our discussion. But that was my kind of a brief introduction about things you may need to beforehand when you come across such a paper that tries to provide solution for oral health problems. So if you have questions at this time, I would be happy to answer. If not, maybe we can discuss the paper in more detail.
Thank you very much. That was very useful. And I think all the audiences now know something about this AI and its application and implementations in health. So, okay, if there's any question at this point, I just have a question. Would you please make an example of, for example, having an unstructured model in health sciences or in dentistry? Better to be in dentistry, but even in health sciences, an example of using unstructured model.
So the image, when you're working for computer vision AI models, image is one example of unstructured data. The other example is text. For example, you have patient notes and you have a bunch of text, and you want to provide some understanding what is the, for example, chief complaint of the patient without going explicitly into the patient note. So you feed the patient note to the system, and the system detects the chief complaint of the patient. And structured data is just something tabular. So it's something clean, and it is something that we are used to work in every day. Yeah, thanks.
Okay.
Great question.
Thank you very much. Okay, any other question? Maybe we can take a look at chat box if there's any question. Okay, okay, no, there's no slides. There's no slides, so no problem if you cannot see any slide. Okay, so okay, it seems that there's no question, so you can. I think we can continue, and maybe during your presentation, then if there's any question, we can discuss about that.
Yeah, of course. And just one note that I'm trying to provide a Medium blog post about what we just discussed here, and it will be ready in about 2 weeks. So if anyone is interested, I would be happy to share the slides with them at that time. So regarding this systematic review, specifically what we done was that there were a lot of studies in the literature on the X-ray images. If you look at in the literature, there are systematic reviews, there are original papers that try to use AI models to detect different types of oral problems from X-ray images, for example, dental caries. And these studies started around 2018. So the first type of successful experiment with this type of AI models was around 2018. And one thing is important is that to draw a line between the research, like when you're working with AI model, between research and what is commercialized or works in a dental setting. So in terms of research, the models that were built for X-rays back to 2018, and there are commercialized models that were introduced around 2021, and they work really great. But the problem with the X-ray is that they are towards clinician and clinical settings. What we wanted to understand is that how these AI models may work for the general public. For example, if you're working in remote areas, you don't have any dentist, there are no X-ray devices. Can a patient, with just using their smartphone, have type of screening, not diagnosis, to say that if they need to visit a dentist, like some type of triage? So that was the main goal of doing this systematic review. So we look at the literature, try to find out like what is available, and not surprisingly, the number of publication on oral photograph, the type of image, is much less than panoramic and X-rays. So what we understood as a result of this conducting systematic reviews, we were interested in, first of all, if it works, like if you have an AI model, does it work to predict dental caries? And if it works, what is the differences between different sensors? And for that, we were interested in 3 sensors: a smartphone, professional cameras, and intraoral cameras. And we try to separate the results based on these 3 sensors. Overall, we found out that these models are promising, and to a sense not comparable to radiographs, of course, and there's a differences between the 3 sensors, saying that intraoral camera provided the best result, then professional camera, and then a smartphone. So that was type of the main result. The other reason we did this systematic review, not to provide a conclusive results if we should use it or not, but to shed a light on what are the challenges and what are the opportunities. And there are many, many challenges right now if we to improve, and if someday we want to use it in a real setting, like you have a product, for example, and it is reliable, and you want to tell a patient or a person in public that you can use it for a trustworthy screening. So I can describe and delve deeper into these challenges if you're interested, but before that, if there's any question, I would be happy to answer.
Thank you very much. Okay, any question? Maybe you can also ask your question just by raising your hand, and then you will be unmuted and you can ask your question. But otherwise, you can write down your question in the chat box. I think there are many questions because this is a field that very interesting. But maybe after presentation and discussion, they can ask their question. To be honest, I made a mistake regarding my question. I wanted to ask about unsupervised model, not unstructured.
Unsupervised.
So an
Yeah.
example of a supervised model for.
Yeah, thank you so much. Actually, it's really interesting topic, unsupervised learning, but very limited application in healthcare. Because in healthcare, you do not have the opportunity to make mistakes.
Yes.
And the way not to make mistakes is to have a subject matter expert to say what is the ground truth. But if I want to provide an example, like a general example, maybe not in healthcare, like you have a data of dimension of clothes, like a t-shirt. And you have a t-shirt like a small, medium, and large, and they have like different dimensions like height and width. And you have this data of height and width, but you don't have this label, like what is, and which one is small, which one is medium, which one is large. So you feed all of this data into the machine, and the machine train itself and understand a cluster of the data. So it understands this bunch of data goes into one cluster, the other bunch goes under one cluster. So at the end, you have 3 clusters, and you have a sense of what's going on inside your data. So it was like maybe a clear example, but the unsupervised learning is capable of doing so much more, like when the differences is not that tangible. And the other maybe usefulness of unsupervised learning, nowadays we have semi-supervised learning or self-supervised learning. And it is more technical. So the reason they came up, the researcher came up with this semi-supervised or self-supervised, which is something between supervised and unsupervised, is limitation regarding the data. So in the healthcare, you don't have much data, and when you have it, you don't have labeled data. For example, let's say you have a lot of images from or photographs from oral cavity, but you don't have a person to actually come and label them. So to tackle this problem, they first use unsupervised learning, so the machine can understand what's going on inside of 10,000 images. Then instead of feeding 10,000 label data, they feed like 200 data or 300 label data. And in this way, they kind of deal with lack of expertise in labeling the data. So unsupervised learning has its own application, but it is limited right now. And you need a multidisciplinary team to kind of, how do you say it, like make benefit of these models, because it's like a very complex surgery. You know, you need a radiologist to tell you what's going on. For example, you need a surgeon. It is something like you need different expertise, and sometimes it's difficult to form this type of team to tackle this type of problems. Yeah.
Okay, thank you very much. So if you have finished your presentation, we can go now to some points that have been raised by our colleagues here. Or do you want to continue regarding your paper?
Just some points regarding, like, when you read this paper or similar paper, you want to draw interpretation, you should be super cautious, because it's a evolving field, dynamic field. And when we were like trying to publish this paper, like the experience was that the field, like specifically people from restorative dentists, are not super open to this type of research as of now, and the reason is that there are many false positives in terms of the results comes from this type of data. And we have, I guess, 2 rejections before publishing this paper. So it's not easy, like it's not easy to do this type of research. It's not easy to make it to the publication point. And you should be careful because it's a dynamic field. Every week you have a new approach. Every week you have a new model. Every week there's something happens new. It's not like something like you have a publication from 3 years ago and you want to reference to that. Like you should be up to date, like, you know, on a weekly basis. So, and we published this paper maybe 1 year ago, and right now there are much better models and much better data set. So that's the first one. The other point is that, as we mentioned in the paper, the quality of the reporting and conducting the studies are poor in general. And the reason is that if you look at the authors, like the affiliation, most of them do not come from dental field. You have paper like people from computer science, engineers, they happen to have a data set and they built a model, so they don't know about the context. They don't know about the epidemiological concerns around this type of research. So it is important to understand what the authors come from. We have papers that they form multidisciplinary team, like they have engineers, they have dentists. So it differs from paper to paper. The third limitation is the ground truth. As mentioned, and we touched on that in the papers, you need a labeled data to perform this type of research. And the way the ground truth was provided, from 19 papers included, 17 of them did the annotation on the image. So they had a bunch of image and they had a dental expert, for example, on the computer, look at the image and say, this image is curious, this image is not curious. So it was not based on clinical examination or tactile examination. And it wasn't, and none of them was based on histopathological examination. So these are the gold standard. The histopathological detection is the gold standard. If you don't have it, you should do tactile visual examination. If you don't have that, you should do visual examination. So it is important that these ground truths comes from, and by ground truth, I mean the label data, the things that the machine was trained on, that comes from just looking at the screen. And that's why you have high rate of false positive, because if you even try it in your computer, in your screen, it is really easy to diagnose arrested caries as caries. And this is different. And that's why this type of models right now lead to false positives and over treatment. And in a way, you want to provide something good, and this false positive balance out, you know, that impact for you. That's the other thing. And the other limitation is that most of these studies did binary classification or binary outcome. So they look at the image and they said, we have caries or we do not caries. So it wasn't, for example, I think 4 or 5 of them did their dental diagnosis based on the reference standard of ICDAS, which you classify the caries from 0 to 6. 0 means sound, and 6 is the most severe. So right now, the literature does not provide models that tells you about the severity of the caries. And again, it goes back to limited data. If you want to go that much into details, you need to have a lot of data. Nowadays, you need less data with the models that we have right now, but in general, you need a lot of data. So these were like kind of the most important limitations, and they are serious limitations, but maybe the most important ones amongst them is false positive.
Okay, thank you very much. So because of these things that you explained, I think that dentistry would be one of the last jobs that would be destroyed by AI. Okay, so I think now we can go to, and we can have the comments by Dr. Sogoli Rafi'i, our PhD students here. Dear Dr. Rafi, we are now waiting for your comments and points regarding this article.
Hello, dear professors and colleagues, and hello, Dr. Moharami. I am so glad that I have this great opportunity to be in this journal club and read this paper. Um, this paper was so informative for me, Dr. Moharami, and this your introduction in this session was so useful for me. Thank you for your valuable explanations about AI, because it's a hot topic of the science these days, and especially in the field of dentistry, we need more information about it. And about your paper, it was very written very clearly, and in most of the parts, I read. When I was reading the paper, most of the parts were very clear for me, and thank you for this paper. And now I have some questions to ask you just for a better understanding of some points. We gain information about limitations of this new line of research. What do you think about chances and challenges of using AI in detecting caries from oral photographs in the field of dental public health and public screening?
Yes, thank you so much for a great summary and great question. So in terms of how we can use this type of models from oral photographs for public health agenda, what we need is to focus on preventive dentistry, and by preventive dentistry in terms of just specifically confined to caries, is to detect caries on their early stages or incipient caries. Right now, the limitation is that, as mentioned, these ground truths are not based on ICDAS reference or other reference standards. So when you don't have those type of ground truths that tells you, for example, in an image, you have a white spot, you have a caries on an enamel part, you cannot build a model that tell you about incipient caries. And right now, none of the models that included in this paper, or as far as I know in the literature, tackle these problems to detect caries in their early stages. Either the model tells you you have a carie, like a carious tooth, or not. It doesn't tell you what stage is that. So maybe the next step is that first of all, you need an infrastructure and change into a standard of care that you collect photograph as part of your daily clinical examination, and it is already happening. So in an institute that I'm working right now, different departments have started to take photographs from patients besides X-ray. So that's provide an opportunity. Then you need an expert matters, expert matters to come and tell you and label the data that if this tooth has a early stage caries or it has a later stage caries. And if you have this type of data, you then will be able to train a model that detects the caries for you in the early stage. That one point. The other point in terms of public health is to provide a solution or product that everyone can use. And the example is that not everyone has professional cameras. Like you cannot expect everyone have professional camera in the public, or majority of the people have professional camera or intraoral camera. So there've been advancement progress in this kind of field. For example, intraoral cameras has become so much cheaper nowadays. To like Canadian currency, they are $10 to $15 which is compared to 2 years ago, they were like around $100 or $200. So the prices are going down. So it enables the public in a given population to have access to this type of sensors. But maybe even easier than that, if we can have a model that work based on the photos taken from smartphones. There are a lot of challenges in terms of if you want to make detections on photos coming from smartphones. But again, there are advancements, there are some very smart moves in this area as well. For example, one of the approaches nowadays researchers are doing is that to get the ground truth, like the label data from clinical examination and label the photos coming from the smartphone using that ground truth of clinical examination instead of, like, for example, doing that on their screen. So there are advancements, but how far they will go, you never know. But yeah, interesting things are happening.
Thank you. And one of the main objectives of this study was to evaluate the performance metrics, such as image processing. And one of the columns in the table was about image processing. Could you please explain more about what is image processing and what types of this you mentioned?
Yes, thanks again. Great question. So when you want to train a model or even use a model for interpretation, so there are two parts to machine learning. One part is training the data. The other part is that you have a model that is already trained and you want to use it. For both of them, you need the images be in images or a data or whatever things you want to feed into the model have a specific format. So you cannot feed images with different size to a model and you expect the model provides prediction for you. So there are steps taken before, like the model makes prediction, like, resizing the image and making the contrast like sharper, for example. So the image is ready, first of all, so it can be used by the model. The other things that nowadays researchers do is augmentation. And why they do augmentation? Because we don't have data. So for this type of deep learning models, you have lots of data. For example, in non-health, you have a data set, ImageNet. If you search it on Google, like most of these models are built on this type of data set. And they have millions of images, like cat, dogs, and labels. So this is type of the data you need. Because you don't need that much data in healthcare, what they do is that, for example, you have 5,000 images, and these 5,000 images, you augment them. And by augmenting, it can be something simple, for example, flipping the image, mirroring the image, like producing some variation of the image. And then you concatenate that augmented data to your original data, and instead of 5,000 images, right now you have 20,000 images. And then you train the model using this 20,000 image, which is even more generalizable to new population. And maybe I forgot to mention this during the discussion. It happens a lot that you have a model and you built it on a specific population, for example, on patients from your institute. But that model does not necessarily work on patients from different institutes because of various reasons. The simplest one is the prevalence of caries is different between the two populations. So you need to provide a model that are generalizable. So augmentation is one way to do it. Doing multi-center type of studies is another way to do it. And there are other approaches that's currently used. So to some degree, they're successful, to some degrees not.
Thank you for your complete explanation. in the method part, your paper was written very precisely and comprehensively, and it was very useful for me. And every part has reference, and it was very interesting for me and very useful. And it was great. Um, It was mentioned in the result part that two-stage models didn't have significant advantage compared to one-stage models. Could you please give us a brief information about the main difference between these two models?
Yeah, of course, again, thank you for a great question. So it might get a little bit technical. So when you're doing object detection is type of model you draw boundary box like this square around your outcome. You have two types of model, one stage and two stage. And for two stage, you're feeding your data for inferences. Like you imagine you have a trained model and you want to use it. The way model works, it feeds the data two times inside its circles. One time, it detects the area of the interest, but it does not exactly know what's going on. But in the second time, like the data is fed, it tells you exactly where is the caries, what is that boundary box. So because you feed the data, the data goes through the model two times, they call it two-stage models. And they have some advantages and some disadvantages, this type of models. They are more accurate, but they are computationally expensive. Whenever you're working with AI model, this computationally expensive is a term that you come across and super important. Why is it important? Because if you have a model like an algorithm that is computationally expensive, you cannot have it on edge devices. And edge devices, the examples are a smartphone or intraoral camera. So you have a limited processing power, and these models cannot be applied or does not work with this type of devices. On the other hand, you have one-stage model, and this one-stage model, for interpretation or inferences, the data is fed only once to the model, and it provides prediction. And these are lightweight models, and they can work on a smartphone. So you do not need a computer to run these models on them. But they are less accurate in general terms. They are less accurate compared to two-stage model. So one of the interesting things or our finding in this paper was that there were no differences between two-stage model and one-stage model for caries detection, meaning that there were studies that use both two-stage and one-stage model, and they did not see significant difference between these two.
Thank you. As we discussed about the false positive diagnosis in this method, do you think that AI in future can distinguish active and passive caries, which can lead to reduce these false positive diagnoses?
Yeah, again, a very good
Prediction.
question. So no one knows because no one has done it so far. And maybe that is the opportunity or area of the research, if someone is interested, can work on. Because right now, no one has worked on the ground truths coming from clinical examination or histopathological diagnosis. So if you have an ICDAS classification, and for example, you scored your caries from 0 to 6, then you need to feed this data to the model to see if the model can detect with this scoring criteria. The assumption is that it works because it has worked like in healthcare, like for example, in healthcare, you have problems, and for these problems, you do not do binary classification or dichotomization. You have multi-class classification, and AI models generally work in other fields of health services. So the assumption is that it will work, but right now, at least I haven't come across a study that did this type of scoring with ICDAS.
Thank you. And my final question is that something it was interesting for me. According to table 2, characteristics of included studies, most of the studies that in your systematic review on this field was from China and other Asian countries. And on the other hand, the developed countries such as Canada, Australia, or UK didn't have any paper, and USA, I think it was just one study. What do you think about the reason of this gap between the studies?
Yeah, again, very good observation. So I can just guess here, like there is no concrete reason why something happened in a country, not in other country. But the main reason is data availability. So, for example, China is very advanced. China is, in general, very advanced in AI in healthcare. And that's one reason it's not limited to dentistry. The other reason is that you have a lot of data and you can access that data. And you have people that label that data. So my observation here is that, for example, in Canada, it's super, super difficult to access data. And you have PHI criteria, personal health information, that takes you more than a year just to get access to a specific data. And when you get access, you cannot get the data out of that repository. So you should go to the center and do your analysis or whatever it is in that type of center. That might be one reason, but again, it's just assumption. Like there might be others reason around it. The other reason that why it happened maybe in North America, it didn't happen in North America, but other places, is that it's important how your healthcare is working. So in North America, we have private insurance, and the companies or startups that work in this type of models, or like not even a startup, big companies, are interested in dentists. So if you look at in the literature, the AI models that develop for X-ray images or panoramics, most of them started in North America because they had customer to sell them to. So it is important if you have a model, who is your customer? And again, it is assumption, like these things are multifactorial. It can be something as simple as that you didn't have a team, like because you need experts from different teams, and it was difficult to form such a team in a specific institute. But if you're interested, or anyone interested to work much more in this kind of a field, there is a WHO group that focuses on AI in dentistry, and they are based in Germany. So mostly researchers from Germany. And I have seen that people from Shahid Beheshti University, not sure should I mention it as a rival university, but there are very, very good researchers like in dental school in Shahid Beheshti that collaborate with that center. Very important publications came out of that collaboration. And maybe it's worth looking like at some of their publications to see how they form this type of collaborations. And yeah, there are different initiatives. Some of them started in Europe. Like as I said, we have really good teams in Iran. A lot of people in Sharif universities, when I see the papers, there are a lot of people from Sharif universities has collaborated already with dental experts in different universities in Iran, and again resulted in very great publications. So it is happening here and there, and it's going. So there are different factors, depending on the environment, it may change. Yeah.
Yes, thank you for your presentation and discussion and your explanations. I hope to more publications in this field in dentistry from you and other scientists.
Thank you so much for having me. It was such a pleasure.
Okay, thank you very much, Dr. Rafi, for
the
and also Dr. Muharrami for clarifying explanations. Just one point regarding false positive. From public health view, I think it would be better if we had more false negative, because we want to always be conservative and postpone intervention as much as possible. Maybe in the future we have more false negative, and would be better for those who are working in the field of public health. Okay, so if there's any comment or question by Dr. Shamshiri, maybe yes, you can.
Hello, Dr. Muhammad. I'm Ahmad. I'm not so good. I use her device only. I have a question regarding F1 score that used in this article, and I see that it's popular in AI studies. It consists of two indices, precision and recall. And in case of medical studies, precision is equal to positive predictive value, and recall is synonym of sensitivity. And as you know, sensitivity has no relationship to prevalence of the event in the population, but the precision or positive predictive value is completely related to the prevalence. So we expect that F1 score in population with high incidence or prevalence of the dental caries became higher than those countries or populations with low dental caries. I try to find some points in your study picking up or study selections as the inclusion criteria for calculating F1 score for those studies that designed in a cross-sectional manner rather than putting a specific number of dental caries for AI detection and a specific number of caries-free cases. What's your explanation regarding this point?
Thank you very much. Great points and very true. So that was one of the other limitations in studies, because these studies come from non-dental or non-medical, some of them like researchers. In some of them, we didn't have even prevalence of the dental caries, so it was not reported. So at this stage, it's difficult to make comparison because we don't have a full picture. And that's why we suggested that in the future studies, we need have a better reporting standards. But to your point, we recently received a letter to editor for this work, which raised some interesting points. And is that even F1 score is not by itself enough. And like in terms of not, you need to have F1 score, and you also need to look both sensitivity and specificity besides precision. So looking at the F1 score, sensitivity and specificity, then you have the like a more comprehensive picture of what's going on. But right now, most of the studies has not reported this, and they have not even reported if they match the data. The assumption is that there was no matching, so it wasn't like they put 500 Caries teeth, then they put 500 sound teeth, something like that. They just grabbed a bunch of images and they made their prediction based on them. So they did not did those sort of matching that maybe you expect in case control studies.
Okay, thank you. And do you have any subgroup analysis regarding the prevalence of the dental caries between different countries in your data set?
No, we
Because
did.
the 95% confidence interval that reported was wide. I think if you perform some subgroup analysis by this way, maybe you get more precise F1 scores for different countries.
Yeah, true. But to do that, again, great point. We need the studies to be, first of all, methodologically, and also in terms of reporting, the clinical reporting, be somehow homogeneous. So this is the next step of maybe synthesizing the data and the results. Right now, there are very, very variation and heterogeneity in terms of methodology that kind of forbids this type of synthesizes. So, for example, for example, the sensor of the data, the camera is different. We do not who took the photo even like from these papers because they do not like touch on that standard. So it has not been reported if the patient themselves took a picture, if their relative took a picture, like what was the setting, what was the illumination. So there are many things that need to be standard. Then you can take a step forward to do the subgroup analysis. The only subgroup analysis that was possible and was done as part of a original paper, so we have not done it to the original paper, that was the differences between primary caries and secondary caries. And they found that the models work better for primary caries than secondary caries. So that was the only maybe subgroup analysis that was done in one of the studies. Yeah.
Thank you very much.
Okay,
Thank you very much.
So, is there any comment or question by the other audiences? Okay, if not, Dr. Moebi, please, you want to say? میوت نمیشه. میخوایم با
Okay. Hello, Dr. Muharrami. I'm very happy to see you after years, and thank you for giving us your time. I know that it's late in the evening, in the night, of course, and I hope that we can have more collaboration in future too.
Yeah, of course. Thank you so much for having me and the invitation. It was such a pleasure to have opportunity to talk with you all again. And I hope it was useful. And of course, like I'm open to any type of collaboration if there is an interest on your part. And I see the future in this realm really bright. Specifically, it is related to public health. So if there is anything or any potential projects that you have in mind, or you wanna start like developing something from the scratch, I will be more than happy to collaborate in any capacity.
Thank you very much indeed.
Okay, thank you very much, and thank you all. Maybe we can have our last points in فارسی. خیلی ممنون آقای دکتر محرمی، تشکر از لطف شما، وقت گذاشتین، آخر وقت هم هست برای شما. یه عکس گروهی اگر بگیریم، اگر کسانی که میتونن دوربین بدن باز کنن دوربینشون رو، یه عکس گروهی هم بگیریم خیلی خوب میشه.
خواهش میکنم، باعث افتخار بود و خیلی ممنون که دعوت کردید و میدونم صبح شما هم هست و اینکه ببخشید دیگه سر صبح مزاحمتونم شدید.
اختیار دارید. خیلی ممنون، خیلی مفید بود توضیحات
قربان
شما. واقعا این فیلد خیلی رو به پیشرفتی هم هست و انشالله در آینده از شما هم بیشتر میشنویم در این حوزه. خب اگه
انشالله
همه
لطف دارید.
سلامت باشید. همه کسانی که میتونن امکانشو دارن فکر کنم حالا باز کردن دیگه. تا بچه‌ای که آره یکی از این لپتاپ‌ها رو فکر کنم گرید ویو میشه، اون گرید ویو رو بزنین و آره چه مال ما که خوب نمیشه. خب همه آماده هستن، بگین دیگه کی میگیره حالا. یه پرینت اسکرین بزنین، یه پرینت اسکرین. آره بفرم. پرینت اسکرین رو بگی. آره دیگه پرینت اسکرین بزنین تموم. منتها این ویو نه، ویو چیز باید زحمت بکشید. خب بذار من بیام بفرمایید. خب اونجا یه اونجا اونو باید بزنید روی، حالا هر کدوم بزنید گالری رو بزنید. خیلی خوب. حالا یه پرینت اسکرین بزنین حله. بعدش باید یه جای عکس رو پیست کنید.
1 2 3
حالا اونو به جای پست کنیم.
لحظه من نمیاد.
برسیم پیست کنید. تو یه فایل پاورپوینت مثلا
پیست کنم.
خب خیلی ممنون.
تشکر
تشکر
از همگی. تشکر شما اگر جلسه رو قطع می‌کنیم. ان که موفق سلامت.
روز خوبی داشته باشید.
خیلی ممنون. خدا نگهدار. خدا نگهدار.